All right. Well, I want to thank you all for attending our first virtual learning cafe entitled Disruptive Mood Disorders in Youth. This is presented by Dr. Caleb Corwin. I'm Drew Berkeley. I'm the psychologist here at the Center of Excellence. First, just a few things about this webinar. You're going to find that your video and audio are muted. And so if you have a question, if you want to please just use that feature to ask any questions, that'd be great. Dr. Corwin and I will make sure your questions get answered. This presentation is also going to be recorded and presented on YouTube in short order. And at the end of the Learning Cafe today, if you will receive an email with our customary survey and a few additional questions about your virtual experience today. A certificate will also be emailed after you complete the survey. I'm going to ask that you please fill out that survey so that we know what went well, what did not go well, so that we can improve with your feedback. And if you'd like a copy of Dr. Corwin's presentation, a link will be sent out with a survey where you can view his presentation. First, I'll say we're pleased to introduce Dr. Caleb Corwin here today. We're very honored to have him present here with us. And so just a little bit about Dr. Corwin. He completed his master's degree in clinical psychology at Western Carolina University and his doctoral training at Louisiana State University. Dr. Corwin completed 2 years of postdoctoral training, the first with the Child and Family Therapy Clinic at Kennedy Krieger Institute at Johns Hopkins University, and the second at Cherokee Health Systems. Dr. Corwin currently works at the CHS office in Newport, where he provides traditional outpatient therapy, and at the office in Knoxville, providing behavioral health care with an integrated primary care setting. Dr. Corwin has been involved in disseminating Cherokee Health System's model of care by hosting training academies at the Cherokee Health System's Knoxville office and providing tailored consultation trainings on site at provider agencies across the country. Dr. Corwin's primary clinical interest is helping families who have experienced trauma. So without further ado, I'll give you Dr. Caleb Corwin.
All right, so you can, Drew, you can hear me? Give me a thumbs up. All right, so I'm unmuted, so I've gotten that far in. Well, hello everybody. This is going to be an interesting experience presenting to, it looks like 101 of you at the moment, and not being able to see anybody. So I'm just going to assume that everybody's smiling, nodding, and enjoying this throughout the duration of the presentation. But seriously, if you end up with questions, type them into the chat box. Let me know. Questions, comments. Some of them I may punt to the end if I feel like I'm going to get to them at some point during my presentation. Others I'll try to address in the moment if I'm not already planning to get to it later. So I hope everybody's quarantine is going well. Make sure you pay attention, because if I want to, I'll just click a button and put you center screen with your video. Just kidding, I can't do that. You're all fine. But you know, try to pay attention as best you can. All right, so some of you have heard me talk about this in the past. Drew, you got my screen up, thumbs up or whatever. Can you see what I'm, all right, cool. All right, so everybody can see my screen. And I'm happy, like Drew said, we're happy to send this presentation. You will get a copy, an ability to access this later. So don't worry about that. I wanted to talk today about disruptive mood dysregulation disorder because it is one of the newer diagnoses for children. It came out in the most recent edition of the DSM5, or the DSM5, and it's one that we're seeing increasing numbers of, but I know that there's been confusion in understanding it. What is it? How do we treat it? And so I have worked to try to compile as much information on this as I can to share with you. I'm going to go ahead and be clear. This is not an exhaustive presentation. This is not going to get into all of the nitty-gritty details regarding this. This is kind of a intermediate overview of this topic to help give people some guidance in how to better understand this when you're seeing this diagnosis on one of your patient's treatment plans, or when you're considering diagnosing this treatment or this diagnosis for one of your patients. So all right, we're off, so it's working. All right, so one of the reasons why we're talking about this today, and one of the reasons why this diagnosis even came about, is because what we started to see was this trend in a dramatic increase in the rate at which bipolar disorder was being diagnosed amongst pediatric patients. This came about because around in the 90s, there started to be talk that amongst pediatric patients, bipolar disorder was presenting differently. Whereas with adults, we were seeing this episodic mania and irritability, which would occur. With pediatric patients, they were like, oh, it's not episodic with pediatric patients. It's more of this chronic irritability. And that led to a drastic increase in the diagnosis of pediatric bipolar disorder. And then at some point, once we started diagnosing bipolar in pediatric patients at an accelerating rate, people started to pause and say, wait, what's going on here? Is this really, are we really seeing that much of a dramatic increase? Or are we actually accidentally capturing something else when we're talking about this chronic irritability? The decision was that, yeah, we might be actually capturing something different. And what is that? What is that when we have these children who are struggling with chronic irritability and presenting with that problem? If it's not bipolar disorder, what is it? So we settled on disruptive mood dysregulation disorder. So this is pretty much just straightforward, the DSM5 criteria. When we talk about DMDD, we're talking about kids who are presenting with severe recurrent temper outbursts that are grossly out of proportion for the situation. Kid spills their milk and starts screaming and slamming doors. Kid is told they have to wait their turn and they start cussing everybody out, right? They're out of proportion. They're inconsistent with their developmental level. So one thing you'll see is we're only diagnosing this for kids between 6 and 18 years of age, because below age 6, tantrums are so developmentally normative that it's difficult to gauge when it's inconsistent with developmental level. We also are wanting to make sure that these are occurring at least 3 times a week. Even if a kid has a massive outburst, if it's only once a week or once a month, we're not talking about that kid. We're talking about a child who, even between the outbursts, is persistently irritable most of the day, or angry most of the day, nearly every day. These are kids who everybody's kind of walking on eggshells around all of the time. Symptoms have to be present for at least 12 months. This is not something that just comes and goes. And it has to occur in at least 2 settings, being severe in at least one of those. So if this kid is only irritable at home, we may be talking about some kind of family dynamic related issue and not DMDD. We want to see this, much like ADHD, present in multiple settings. We're only diagnosing it between ages 6 and 18. We also are wanting to make sure that the age of onset is prior to age 10, because what the writers of this, those who made these decisions, were trying to highlight is that they're trying to capture something here that is occurring on a basic level for this child. They're hypothesizing in some ways that this is not something that is triggered by life events, by something else that's going on, that this is something ingrained in a child's physiology to a certain degree. Also really important to highlight that when we talk about this, we're deliberately excluding anybody who has a history of mania or hypomania. So it cannot coexist with bipolar disorder. You cannot have a diagnosis of disruptive mood dysregulation disorder and bipolar disorder. You also have to make a decision, if you're diagnosing this, between whether or not you're diagnosing oppositional defiant disorder, intermittent explosive disorder, or disruptive mood dysregulation disorder. Those are not allowed to be comorbid. And that's going to be important as I talk about some of the research that's come out about this, because that distinction is important to consider when drawing conclusions from the research that exists. One disorder that's notably absent from that is ADHD. DMDD can be comorbid with ADHD. A child could receive a diagnosis of both ADHD and DMDD. So a lot of people started to say when that came out, like, oh, you're just making this up. There's nothing to that. You're really, all this is this is just a new label on pediatric bipolar. That's all that we're talking about here. We're not talking about something new or revolutionary. This is just pediatric bipolar disorder. Really, if you look at some of the research that's coming out, though, there is something to this. This distinction is incredible. It is fairly important, which is why I wanted to talk about it today, because unfortunately, despite having this new verbiage, this new diagnosis to utilize, people are using the DMDD diagnosis, but assuming that when they give that, really they're just diagnosing childhood bipolar. They're just diagnosing childhood bipolar light. Hopefully I can help you understand that that is not the case. That is not what we're talking about here. This is not pediatric bipolar. There are several reasons why I say that fairly confidently. There have been multiple research studies looking at the differences between those two things. And if we look at bipolar disorder and disruptive mood dysregulation disorder, we see several key differences. One of the main differences is in the primary symptom. When we talk about bipolar disorder, we're talking about mania. And what we've seen as we've looked deeper in with DMDD is that pediatric patients with bipolar disorder present very similarly to adult patients with bipolar disorder. We see this episodic up and down. We are seeing them engaging and experiencing these manic, hypomanic episodes where there's this increased activation. With kids with DMDD, the primary symptom, the primary deficit is related to that irritability. They are just baseline irritable. Anybody who's ever seen one of these kids, a kid with DMDD, you feel it when you walk in the room. It's like, hi, my name's Dr. Corwin, nice to meet you. And already they hate you, but not in the way that like some kids kind of tend to hate you when you're a mental health professional and meet them. It's like this like deep hatred, like, that's my experience with it, right? But it's just this irritability for everything. Everything's bad. It's like Oscar the Grouch and angry all the time. We also see differences in how the problem comes. With mania, again, we're talking about this episodic nature of the condition. When we're talking about DMDD, we're seeing things occur much more chronically. We know that irritability is a symptom of a significant percentage of our mental health conditions that we're diagnosing. And we know that irritability is also very common amongst bipolar disorder. And it may be one of the key symptoms to bipolar disorder. But even if we're talking about that, for a child with pediatric bipolar who has irritability, we see that irritability come in episodes, in waves. They're increasingly irritable for a week, 2 weeks, a month at a time, and then that fades away. When we talk about kids with DMDD, what we're seeing is that irritability sets in and is there for months, up to a year, right? Or years, right? We're talking about it needs to have been present for up to a year for us to even diagnose this condition. So we're talking about different presentations. We also are we're finding differences from a genetic perspective. These two disorders seem to have a different genetic load. We're finding that there's a much higher rate of, a much higher weighting to genetic ties for patients with bipolar disorder. The weighting of that is much higher than it is for DMDD. This may be a bit of a false finding, however, because in order to do that type of testing to see how heritable a trait is, we really need clear-cut diagnostic criteria. And as you can see, the study I cited here is from 2007, and the real diagnostic criteria that we're talking about here weren't officially out until 2015. And so there are some differences here, some significant differences, or some potential problems with that. But even still, we're still seeing some differences there. And one of the most glaring and most obvious differences is when we talk about longitudinally, what happens with people who are diagnosed with these two conditions. we know that if you look at the bottom, if we have a child, a small person, small adult who's diagnosed with bipolar disorder, if we follow them over time, we expect that they grow up into an adult with bipolar disorder. When we're seeing these children who are diagnosed with DMDD, this persistent chronic irritability, this rage that's coming out multiple times a week, they're not growing up to be adults with bipolar disorder. That's not happening. They're growing up, they have a different trajectory. Those kids who have that rage and irritability are growing up to be adults with depression and significant anxiety. Again, for me, one of the most convincing pieces of evidence that we're talking about something different here. Because if this was truly pediatric bipolar that we were simply capturing, we would expect that they would grow up to be adults with bipolar disorder. It's not happening. And it's not because somehow we're doing some miraculous intervention that just treats the mania and leaves them with the depression. This is something different. Also see, there's a tremendous amount of overlap between DMDD and other mood disorders, depressive disorders. We're seeing that significant numbers of kids who are diagnosed with DMD are also receiving diagnoses of major depressive disorder and persistent depressive disorder. And this is my Venn diagram. And I always like to throw in that every good presentation has a good Venn diagram. This is the one I have in here. This is from a very recent study where they're using the criteria. One of the things to note here is there's no overlap between bipolar disorder and DMDD. But that's also not a very significant finding because you can't, based on the current criteria, you can't have both of those diagnoses. So there's no way for those to overlap. So I'm not trying to highlight that in this picture. One of the reasons why this distinction matters is because if we were to assume that what we were talking about here was simply pediatric bipolar, if disruptive mood dysregulation is just our new term for bipolar disorder in kids, that they're going to grow up to be bipolar adults, then we would just want to start them on the treatments we know work for bipolar disorder. We know that that's not a great idea. Some initial studies have shown that mood stabilizers aren't showing benefits for disruptive mood dysregulation disorder or severe mood dysregulation disorder, which is, I'll get into in a second explaining what that is. And that's significant because sometimes we're using lithium as our mood stabilizer, and there's a huge risk for toxicity. There's a significant risk with that medication, for using that medication. And I highlight this to say we need to be careful because we're not seeing, this is not pediatric bipolar. The other medications that are often used to treat people who have significant bipolar disorder are antipsychotics. Now I'm going to talk out of both sides of my mouth here, but what we're seeing is, for the most part, we're seeing that those medications are being widely prescribed for kids who have bipolar disorder to treat the irritability and aggression, and with some result. That, we often will see kids with bipolar disorder who are on risperidone, and we're still seeing that for kids who have disruptive mood dysregulation disorder, and the jury's still out on as to whether or not that's beneficial. I think one of the things I want to highlight, though, is those are not, while those might be frontline treatments for bipolar disorder, they may not need to be for disruptive mood dysregulation disorder. The other reason why it's important to understand the distinction is the last medication a psychiatrist is going to put somebody with bipolar disorder on is the stimulant. They're absolutely not going to do that because it can trigger a manic episode. They're also going to be very cautious about putting a patient on an SSRI for the same reason. And that assumption may be closing the door to a treatment avenue that may be wildly effective for this patient population. And in fact, some of the recent studies looking at DMDD have found that those medications are somewhat effective, that we know that DMDD is incredibly comorbid with ADHD. It co-occurs really frequently. One of the biggest criticisms of DMDD is that it's highly comorbid with several disorders, depression, anxiety, and ADHD. We're also starting to find that kids who have comorbid ADHD and disruptive mood dysregulation disorder are benefiting from treatment for ADHD. Stimulant medications are actually reducing some of their irritability and some of their outbursts. Again, we need to know the distinction between this disorder and bipolar disorder, because if we are thinking of it as bipolar disorder, we're going to rule that treatment out altogether. The other thing is, we know that SSRIs are also effective for kids who are diagnosed with DMDD and comorbid anxiety and depression. We also know that these kids with DMDD are growing up to be adults with major depressive disorder and anxiety. And it may be that these two medications are more the avenue and the route to go for treating that. Now, I want to be clear. I am not a psychiatrist. I'm not giving anybody a recommendation on who's a medical provider on doing this. I'm merely stating that this is what the research is showing to be effective for this. And I encourage anybody who is a medication prescriber to go out and look into this yourself. You can access the presentation. I'm happy to send you any of the studies. But we need to understand that distinction. And as mental health professionals who are not prescribers, it's important for us to understand this distinction, because we have a clinical lens that we can bring to the table for our patients. And we can bring and kind of looking through these things, kind of be a critical eye to check and see what's going on. Does this medication regimen seemingly make sense, even though we're not the ones who will make those changes? So I hope I'm kind of starting to make a convincing argument for this, right? That this is something different, that we're talking about. This is not pediatric bipolar disorder. And I think my goal in this presentation is to say that as many times as I can. DMDD is not pediatric bipolar disorder. If I could hit like 150, it'd be good. Really, though, it's also important to understand that the research on this topic is incredibly new, and there are some flaws with it. What we see is that most of this research, especially anything dated prior to around 2015, is based on research for severe mood dysregulation disorder. This was the originally proposed diagnosis before we had DMDD, as they were working on it before, in order to make an argument to add it to the DSM. They used this as a working diagnosis. It was similar in a lot of ways to what we ended up with for DMDD. Some of the key differences, though, are that it targeted an older population of kids, and it also included hyperarousal symptoms. Things like insomnia, distractibility, racing thoughts, agitation, pressured speech, things that are much more similar to a manic episode. So a lot of the research outcomes that have used that diagnostic criteria are likely, if I had another Venn diagram, this would be a good place for one, maybe next time. But what we would probably see is kids with severe mood dysregulation disorder, kids with bipolar disorder, and kids with disruptive mood dysregulation disorder. There would be some significant overlap between the kids who have, there would be kids who are diagnosed with severe mood dysregulation disorder who may well have had bipolar disorder going on. They've removed that criteria in an effort to completely distinguish disruptive mood dysregulation disorder from severe mood dysregulation. Severe mood dysregulation is not something you can diagnose. It did not make it into the DSM. It's more of a research diagnosis that is utilized. And that muddies the water with any of the early research we have. This research is still very much in its infancy. Another thing that makes it challenging is assessing for irritability. How do we, this is the point where if we had a group and we were all in the same room, the good old days where we could do that, I would ask, how people assess for irritability. I won't do that because digitally that's going to take a while. But think about this. Do you have any really good ways to assess if you're trying to assess the level of irritability in a patient? How do you do that? I don't have any great measures. If that's my primary question in an assessment, it takes a lot for me to fully get at that question. If you ask me to do, if the primary difficulty is hyperactivity or inattention, I've got lots of measures that I can reach to. If the primary question is related to depression or anxiety or trauma, I have lots of tools that I can reach to. If the primary complaint is irritability, I don't have a great gauge for that. There are some things that people are starting to use. As you can see, though, they're just kind of piecing apart other measures to make it work. Using the ODD module from the KSADS, using depression items from a preschool psychiatric assessment, using some select items from the Connors. Again, we're piecing things together here. We don't have it. And we don't really have a clear-cut operational definition of what we're talking about when we talk about irritability. Irritability is one of those things where everybody kind of knows it when they see it, but getting a clear, hammered out definition hasn't really happened yet. And so we all kind of universally agree that somebody who's easily annoyed or angered, I talk about it as somebody who loses their temper quickly, has a shorter fuse. You never know what's going to set them off. But other people may share different views of that, and that doesn't mean I'm right and they're wrong. And one of the things for a research perspective, in order to really gain an understanding of what we're talking about with this disorder, it's going to take more focus on that, right? More focus on understanding, getting a clear, consistent language for what is irritability. We have clear and consistent language on what is a manic episode. We have clear and consistent language on what is a depressive episode and what constitutes that. We don't have a clear definition of what constitutes irritability. We also are seeing reliability is not great for this diagnosis. One of the reasons for that is likely because it's new. We're not familiar with it. We don't have as much repetition. We weren't trained on it in graduate school and then haven't had a ton of practice on it going forward. Although now that I'm saying that, I'm realizing that there are some of you who probably did have training on it in graduate school. I'm just older at this point, but I didn't. And for those older than me as well, that wasn't something that was part of their graduate training. We find that our reliability isn't great between each other, which is true for a lot of diagnoses, but really bad. I mean, if we're talking about reliability at 0.06 and 0.11, like we're only agreeing like 10% of the time on this diagnosis. Not awesome. And then we talk about stability of the diagnosis, and we're finding that only 19% meet criteria at 12 and 24-month follow-up. So something is going on here. Even if I do the assessment with this kid now and then see them again back in 12 months, only 19% of the time am I giving the kid the same diagnosis. Again, multiple factors could be at play there, but not so great. So there are some questions about how we're capturing this right now that definitely have room for improvement. Can I check in and see if there are any? Oh, I don't know how to check in and see if there are any questions. But
yes, we do have one question, Caleb.
Oh, let's hear it.
It was from Katie Butler. Many of our youth in foster care are being diagnosed with this, as far as talking about disruptive mood dysregulation disorder. How is development stunted by trauma included in this assessment diagnosis? Many of our youth in residential are being slapped with this when they have previously had major depressive disorder or pediatric bipolar disorder. Most kids in residential would be baseline irritable. This is the new trending diagnosis with our residential facilities, and I am fearful it is misguiding treatment intervention.
So excellent question. And I'm going to punt that one because I'm actually about to address that. And I will say, Katie, if you feel like I don't address that question, clarify after I've talked a little bit more, because I think I'm going to get to exactly what you're alluding to. Because we're seeing this as like a hot new diagnosis, and that is causing some problems. One of the things I want to highlight is, we want to make sure it's an appropriate diagnosis, because that's going to alter our treatment plan. But we'll talk later. Oh, quickly. All right. All right, so I want to talk about because when we diagnose, we want to make sure we're careful, right? Kind of what you're getting to, Katie, to a certain degree, is that we want to be careful and cautious about how we're doing this. And we want to not just be giving it because it's the hot new diagnosis. Oh, this is a new thing. This kid has been really difficult for me to treat. It's not something that's going on with them or me. It's this new diagnosis, right? That's what it's got to be. That's what explains it. So some things to be cautious about when considering this diagnosis. We know that this diagnosis can't be diagnosed for kids who are under age 6 because tantrums are incredibly common in children under 5. 85% of children under age 5 have regular tantrums. So first and foremost, for young kids who come in with this diagnosis, which has happened, it's not appropriate. And I am knowledgeable enough to know that just because the criteria says you can't diagnose it doesn't mean people aren't diagnosing it incorrectly, right? So that should be a red flag to somebody. The other thing is these tantrums are severe and chronic. We are not talking about the kid who has a tantrum when he's grounded once a month. We're not talking about a kid who stomps his feet and huffs and puffs and walks away every time they get a consequence. We're talking about a kid who flips the table and cusses everybody out when he's told it's time to do his homework, right? We're talking about a kid who does that multiple times a week, like every other day or every school day, right? These are severe chronic tantrums. We're also seeing that it's incredibly common with ADHD and ODD, to the point where 80 to 91% of cases diagnosed with disruptive mood dysregulation disorder also carry a diagnosis of ADHD or ODD. That I don't know exactly what to make of it. If I'm hypothesizing, I would say that part of that is we're talking about this is a deficit of executive functioning to a certain degree, as well as a deficit of mood. And we know that our kids with ODD grow up more often than not to develop depression. And this may be more similar than different to ODD, but capturing more of that irritable mood flare, conceptualizing the mood more as part of the diagnosis than we were doing with ODD, which is not my favorite diagnosis. And then, we talk about it with ADHD, and I think a lot of times it's that executive functioning deficit and the overlap between those two, because kids, if you're having severe tantrums, you're behaving rather impulsively. And so they're going to hit on a lot of those measures as well. Again, we talk about, is it really just ODD? Right now, we don't have a clear enough research base to differentiate those two. There is some research coming out. John Lockman has made a proposal that really we're talking about two different subsets of ODD that have like multi-finality. We're seeing them start in the same place. They're diagnosed with ODD in childhood. And we know that a significant percentage of kids with ODD go on to develop conduct disorder and later antisocial personality disorder. But we see that flow. But Dr. Lockman is proposing that there may be this alternate trajectory that we see for other patients. That for some of our other patients, what we're seeing is they're diagnosed with ODD when they're younger, and they grow up to develop depression and anxiety in adulthood, and that maybe DMDD is just capturing that branch of children, and ODD in some way maybe we'll be able to eventually find a way to differentiate between those two branches of the tree so that they are separate diagnoses, and ODD becomes a clear-cut diagnosis that is capturing a higher percentage of kids that go on to develop conduct disorder, and DMDD is capturing more of the kids that go on to develop depression and anxiety. Again, we don't have a great way to do that right now. We're still working on that as a field, right? And it's something that is going to take time, but also something that's worth considering, right? Taking and utilizing as part of your clinical thought process about what's going on. to try to, for these kids who are presenting with these severe tantrums, really taking a close look at what hints or shades of depression also exist. Because as those things are more present for a patient, for me personally, it drives me more towards the DMDD and further away from the ODD. If a kid presents with ODD and does not have very many mood symptoms, they're not very easily upset, they're generally not that irritable, they're kind of able to be laid back, but then just really defiant when they don't want to do something. Those are things that we're going to get better about differentiating with some of our assessment measures. But for the time being, we are left to rely on our clinical judgment and our ability to ask good questions in our clinical assessments. Going to trauma, right? We see some of the risk factors that have stood out for disruptive mood dysregulation disorder include parental substance use, low parental support, and parental hostility, right? To me, that screams a child who is at risk for experiencing significant trauma at an early age. That's the one thing that stood out to me repeatedly as I've looked into this. And it's just embarrassingly absent from the literature to this point. They're starting to, this study in 2020, so very recent study, actually started to look at this, but this was not the primary focus. I'm gonna, full disclosure, I kind of farmed this data out of their research study. They did the analyses, but they didn't highlight these things in the way that I would have expected, because this is the more telling distinction to me. The study took a population, they took recent inpatient stays in two Canadian inpatient hospitals, pediatric inpatient hospitals. And then they looked at different factors for those patient populations. Of the children that were admitted to the pediatric hospital, inpatient hospital for DMDD, 28% had a concurrent diagnosis of a trauma or stress-related disorder versus only 13% of people admitted for other diagnoses. And there was a significant statistical difference there, right? That's not just a happenstance, a coincidental finding. And that stands out as pretty significant to me. They didn't make much out of it, but to me, that's pretty notable, because one thing that's missing here is there's no talk about the differential diagnosis with PTSD or developmental trauma and the role that that might play in the development of this disorder. And in my mind, the things that we're talking about when we talk about DMDD fit perfectly with the reactions we see some children exhibiting when they've experienced severe trauma and neglect early on in life. Again, I don't have confirmation from the literature in that. It's more of a gut feeling, and I've found this, which affirms my belief. So I think somebody could convincingly make an argument that I'm falling to the confirmation bias, but I think that this is relevant and worth looking at. One of the things that also stood out and surprised me is that there wasn't a significant difference in exposure to ACEs between patients that were diagnosed with DMDD in this inpatient setting versus patients who had other diagnoses, depression, pervasive depressive disorder, or any other psychiatric diagnosis. So they were seeing similar rates of ACEs. And so it may be that what we're talking about here is not just exposure to ACEs, but exposure to ACEs in the absence of resiliency factors, that these kids may have equivalent ACEs, but fewer resiliency factors or other risk factors, and therefore they are more likely to succumb to this type of diagnosis or this type of presentation. Of note, and I don't know exactly what to make of this, they were finding that patients who were diagnosed with DMDD were significantly more likely to have been the product of a complicated pregnancy. So some type of insult during the pregnancy, including parental substance use during pregnancy, also gestational diabetes, other things that can occur. And so it may also be that we're talking about multiple different insults contributing to the development of this disorder. A child who is born of a complicated pregnancy and then subjected to significant exposure to neglect may develop this. But again, these are hypotheses. These are, I'm just talking right now, right? These are my thoughts on where this is going. And I think it's ripe for future study. And my hope is that we start to look at developmental trauma disorder as a diagnosis, and then start to look at the overlap between disruptive mood dysregulation disorder and developmental trauma disorder, because I think there's going to be significant overlap between those two presentations. As of yet, we don't have the research to back that up, at least not so far as I have found. And Katie, if that doesn't answer your question, just shoot another one out there, and I'll go for that. Let's see, can I open? Yeah, I don't. All right, yeah. If anybody has another question, just shoot it out there. So, oh, what's happening? Uh-oh. Okay. So I want to summarize this and then leave an opportunity for questions. One of the biggest things we're talking about here is DMDD is a new diagnosis. As of yet, there's still little research on it using the actual criteria that we're using for diagnosis right now, because still the bulk of the research is based off of that severe mood dysregulation disorder. At the end of the day, there are lots of things that we don't know for sure, but one of the things that is glaringly clear, regardless of which research you're looking at, is that this is not pediatric bipolar disorder and should not be treated as such or viewed of as such. We need to understand that this is categorically different, and what we may be talking about, or what we may be looking at, is a pediatric depression, right? For which we don't have a great way of capturing right now. Previously, it's been called masked depression, when kids are depressed and angry and acting out. But again, this is not pediatric bipolar. And really, there's not enough information to say that this diagnosis really informs treatment. You know, if we give a child a diagnosis of ADHD, that informs treatment. We have clinical guidelines to say that the frontline treatment for ADHD is medication. We know that to be highly effective for the core symptoms of ADHD. We know we have treatment guidelines for depression, whereas if somebody presents with mild depression, the frontline treatment is therapy. If somebody presents with severe depression, the frontline treatment is medication. We don't have that for DMDD. This diagnosis is capturing a set of symptoms without really without that diagnosis guiding us then to what the most effective treatment plan is going to be. And that's a problem I have with a lot of the DSM, but particularly with this diagnosis. Some of the things that you can take away with this is people have been working to synthesize and try to come up with those guidelines. We're not there yet. And so this is not a clear-cut, definitive list of what is effective for DMDD, although it is a list of what is starting to show the most promise. There is a fairly recent study which showed very, very promising results for dialectical behavior therapy, DBT, in treating children who present with disruptive mood dysregulation disorder. And anybody who's familiar with DBT, I think if you think about it, it makes total sense. DBT teaches a lot of skills on emotion regulation and mindfulness and just awareness of those emotional states, which for a kid who's persistently irritable and lashing out and acting out inappropriately, clearly would be a very useful skill set for them. And so there's a lot of promise there. And so I think you're pretty much going a path of no harm if you have a kid with DMDD and you recommended some type of DBT therapy. There's also some promising stuff related to CBT, although those studies haven't been done as well as this DBT. They're not as rigorous of studies, so I'm not going to say it as confidently. But there's some indication that even just basic cognitive behavior therapy, teaching problem-solving skills and other kind of emotion regulation skills can be effective. And I think from more of a common elements approach, we can assume that the basic skills present within DBT that are also present in other therapies are also going to be effective with this population. One of the a good bet is combining behavior management with stimulant medication. There have been a couple of studies that have looked at that because we know that morbid kids who have ADHD and DMDD who are receiving stimulant medications are seeing improvements not just in their ADHD symptoms, but also in their overall baseline irritability, especially when that's combined with behavior management, training parents on how to better, more effectively utilize positive parenting skills and practices, consistency, routines, all of positive reinforcement, all of those skills that we've known for decades to be effective when working with kids who have behavioral problems. And the safest, surest bet is behavioral parent training. These kids, we don't know them to be treatment resistant. We do know them to be more challenging to deal with, but we're still seeing evidence from studies suggesting that by utilizing the evidence-based principles present in behavioral parent training, we're still seeing some results with these kids who are persistently irritable. And let's be real, before this diagnosis, we were still treating these kids. It's not like all of a sudden this new group of kids came around. This group of kids was here. If this is a diagnosis, it's been around forever. We just didn't use it. And if a kid presented to the clinic with persistent irritability, most people were leaning towards behavioral parent training and having some results with it. And we find that that's still true even when we look at those children through this lens of DMDD. And lastly, just a plug, research is huge. If you have kids who are meeting criteria for this, there are ongoing studies recruiting for kids who have bipolar disorder as well as kids who have disruptive mood dysregulation disorder. And you can connect with some of the major studies to help further this if you have patients who might be interested in participating in that. Although, let's be real, that's probably on super hold right now. So what questions do people have? Let's see.
We have two questions, Dr. Corwin. One is from Dr. Martha Wyke. Do you know the lower age for DBT?
Oh man, I don't know the lower age for DBT because I am not a DBT therapist. Although I don't know. You got that, Drew?
Yeah, the lower age, at least for the groups that are in Knoxville, mainly at Cherokee Health Systems, and I think there's one at Peninsula, it's usually teenagers. There is DBT for children, but as far as I'm aware, there's not a group for that yet. And so usually we're looking at teenagers 13 and up or a very mature 12-year-old.
Mm-hmm. And I would say, really, I mean, if you look at the DBT skills, there are some of them that require kind of more advanced cognitive knowledge than others, but a lot of those principles and skills are readily translatable to a younger population.
Mm-hmm. And there's another question. Should kids who exhibit DMDD symptoms be segregated from other kids, particularly in school settings?
Oh man, well, so I don't think, you couldn't make a blanket statement like that, right? I don't think you could make that blanket statement for any diagnosis, but also this one. It's really about that specific situation. I mean, is it possible that a kid with DMDD presents with such the degree of behavior dangerous enough to suggest that they need a more restrictive educational setting? Absolutely, that's possible. But just because they have a diagnosis of DMDD, does that mean they're dangerous to other kids? Absolutely not. They're kids with DMDD who be perfectly fine to be in a general education classroom with adequate intervention and support. Now, is a kid with DMDD probably going to need additional resources in school? For sure. We know that kids with DMDD have lower academic achievement outcomes than kids who present with depression, and they have impairment equivalent to kids who have bipolar disorder. So yes, those kids are probably going to need additional assistance in school, and they need to have some type of doesn't have to be an IEP meeting, but definitely probably some type of meeting with the school to talk about ways to support this child, whether it's some kind of check-in, check-out intervention with a positive mentor at school, or some type of more formal therapeutic support in the school setting. But I don't think we could say that just because of this diagnosis, they're more likely, or that they're definitely need to have that.
Dr. Warwick, you can unmute yourself if you want further clarification. I see you posted something in the chat. And those on the phone, if you're joining us on the phone, I've also allowed you to unmute yourself by pushing *6 so you can ask questions. One more thing on that, if you are on the phone and joining us solely on the phone, make sure you email Karen Gray so you can get the link for the certificate. And if you're on video and you have several people who are watching this all in one room, please email Karen Gray again so that we can get you your survey and your certificate individually. But Dr. White, you can unmute yourself if you'd like, and those on the phone, you can also unmute yourself to ask questions.
Somebody said, I'm thinking about the little kids in foster care.
Yeah.
Okay. Yeah. That's a tough population. It's tough. I would argue it's incredibly difficult to treat any child whose caregivers aren't involved. But I think a child who's in foster care, I immediately lean towards the foster parents, right? Their current caregivers, helping to strengthen skills and strengthening that relationship. For my own bias, thinking about this as a disorder which is more probably related to trauma, and then that's like me going out on a limb there. But especially if we're talking about kids who are in foster care, then I think that, you know, we want to foster positive attachment relationships as much as we can. And in the absence of a biological caregiver, we use the caregiver that's there and trying to get them to learn ways to support them. And it may be that we then and then trying to foster the use of those skills in that foster placement. And if successful, then trying to educate the biological parent and get them as involved as we can to help them take over that role and provide that support. Other questions? Anybody else? The question everybody wants to know is, like, if there's no college football season, does that mean that LSU is back-to-back national football champs? And the answer is yes. That will be 2 years in a row. If we don't play this year, by default, we get to continue as national champs for the 2020 season. But any other questions about what I was actually talking about?
Oh my goodness. What have you started here, Dr. Corwin? Anyway, well, I want to thank everybody for joining us on this first virtual learning cafe. And I want to thank very much Dr. Corwin for your very informative presentation. A reminder, please fill out those surveys. They should be in your email boxes right now. If you're on the phone, make sure you email Karen Gray, or if you're several people in a room watching this on video, please email as well so we can get you your proper credit. We look forward to joining everyone next month in May for our Learning Cafe, and we'll be sending out more information as far as registration and virtual. It'll be virtual as well. More information on registration at that time. So thank you, everybody.
Bye. All right. Bye, Drew.
Well done, sir. Well done. Thank you so much for everything, and we'll talk later.
All right. Sounds good. See ya.
Bye-bye.